Thank you so much, Clarinet, for providing this session. One disclaimer on this, that this is not a session of Indian Academy of Pediatrics. It's a session for PG teaching, a PG clinic of E-Gurukul Pathshala. Today we have a discussion on case discussion on nervous system. And for this, we have two eminent experts. So I welcome Dr. Harshruti Shah. She is a senior child neurologist practicing at Rajvi Hospital, Ahmedabad. She was an ex-assistant professor at BJMC and ex-professor at SBKS Medical College, Waghodia. She had done her child neurology graduation from Tel Aviv University, Israel, and fellowship in electrophysiology from Japan. Ma'am has won many gold prizes and gold medal prizes and the Young Investigator Award from Japan. And she is very much interested in teaching the PG. We have her help and expert advice whenever we require. Welcome, ma'am.
Thank you. Thank you.
We also have Dr. Anand Keshwan TM. Sir is a professor of pediatrics in Government Medical College, Thrissur, and he was chairperson of ECHG 23-24. Sir was IAP National Vice President in 2020. He was past National President and Secretary of IAP Neurology Chapter also. He is a national convener of IAP PG Quiz Program from year 2021 till now. Welcome, sir. For today's session, we have presenter Dr. Aarti Solanki and the mentor Dr. Anand Iyer, sir. Anand Iyer is a visiting consultant at at the Institute of GMERS Medical College, Sola. Aarti is the third-year resident in the GMERS Medical College, Sola, Ahmedabad. I also welcome Dr. Baldev Prajapati, sir. Sir is a convener of this module and the stem actually of this module. Without him, this is not possible like that only. So welcome, sir.
Thank you.
I hand over the session to sir.
Good evening, friends. Welcome to this PG session. As already Dr. Nehal said, Dr. Aarti is the presenter for today. She is resident from GMRS Sola Medical College. I request those who are on the screen, Aarti, you can request some of your friends to join.
Yes, sir.
Yeah, so that we can have the good interactions. And even very freely, I request them, they can ask the questions, queries, comments. And even those who are on the attendees list, they can also put on the chat box. We'll look at different times and we'll incorporate all the points in our discussion. With this remark, I request Dr. Aarti to share her PPT and start the history part.
Yes, sir.
Sir, many students have joined the platform.
Oh, fine. I think Dr. Nehal, can you help us to identify them?
Sir, I request all the students to switch on your camera so that, sir, it will be easy to interact with you all.
Yes, yes. I think that's
Rajat is always there from Goa and he is a very active participant.
Right, I know him.
Yeah, other students I don't know, but if they participate only, then the teachers can know. So
Yes,
please,
yes.
students, participate with your camera. Dhaval is there, sir. Dhaval and Rajat are both very nice students.
Yes, yes. Please, Aarti, go ahead.
Yes, sir. Sir, is it visible?
Yes, yes.
Good evening, everyone. Myself, Dr. Aarti Solanki. I'm presenting a case of nervous system under guidance of Dr. Anand Iyer, sir. 11-year-old female child, first by birth order, born of second degree consanguineous marriage, residing at Memnagar, Ahmedabad, Muslim by religion, Informant being father brought to us with a complaint of inability to walk since 1 day, diminished sensation in both lower limbs since 1 day. Child was apparently well till a day before presentation. She presented with sudden onset of weakness of both lower limbs since morning. Weakness of lower limb affected both proximal and distal muscles. Father noticed that initially few movements were present in left lower limb distally, but within few hours, she was unable to move both lower limbs completely. Child was unable to stand or walk. Child was complaining of not feeling anything in both lower limbs since morning. She started having urinary detention. She had no sensation of bladder fullness or urge to urinate. She did not pass stool from last 2 days. No tingling sensation or pain in lower limb or back. No weakness in upper limbs. On asking, there was history of fever with cough 20 days back, which was subsided spontaneously within 3 to 4 days. Some oral medications were taken for that.
I think, Aarti, can you stop sharing for a while
Yes, sir.
before you go further? I think we'll take symptom one by one. Forget regarding the case and details. Suppose, as she said, 11 years old female. Let us take only first symptom, that not able to walk. Suppose, Dr. Dhawan, you are sitting in the OPD, outdoor department, and this patient enters a room. Simply with one complaint only. Forget rest of the part what Dr. Aarti has described. That will take later on. But suppose inability to walk, how you will proceed further? What points you will ask in the history? How will you decide that what is the likely reason? Regarding just one complaint, not able to walk.
Sir, as the patient enters in the OPD, when we see the patient is main complaint is child is not able to walk, then first I would like to ask it is acute or chronic. Is there any ongoing illness is there, or it's sudden in onset?
Okay. How it will help you?
Sir,
for every information what we try to gather, we have some intention, we have some idea.
Sir, in acute conditions like after viral illness, there might be a viral myositis. In such case, a child might not be able to walk.
Okay.
In case of
But
GBS
how will you try to differentiate that this is viral polymyositis and not even the neurological condition like GBS?
Sir, it is
both the children have same complaint.
Yes.
Not a walking.
Sir, it is associated with other symptoms like fever, myalgia, and other things, coryza and all. So,
suppose these symptoms are not there, and many a time these symptoms may not be there, that the viral stage is over.
Then, sir, it is static or in progressive in nature. Initially, child was it's ongoing more and more or not. Then we can differentiate. It's GBS or viral myositis.
Any other, Dhaval, I will give you one important clue.
Okay.
You know that both the conditions, polymyositis and neurological condition like GBS, in both the condition, child is refused to walk, not able to walk.
Not able to.
Yes. Right? But what is the reason in both the condition? What is the reason in the case of polymyositis, post-viral?
It involves, sir,
whether the child does not want to walk or child is not able to walk.
Not able to walk.
And suppose
child is not able to walk, and in viral myositis and all, child don't want to walk due to the pain.
Why? Yes. So that's the point, right? You will try to differentiate whether pain is the factor responsible for not working or really the neurological some deficit, right?
Yes.
And that very simply you can here in the polymyositis, child wants to walk, but not walking due to the pain. While in a case of this neurological condition, whatever it is, even GPS, polyneuropathy or anything, even poliomyelitis, here what is the problem? That in spite of the desire, child is not able to walk.
Not able to walk. Yes.
So that's the thing that you will try to differentiate. Even in a simple any case of the trauma also, child due to this even pain may not be walking, right? So that is number one. Suppose here if you decide that child is not walking due to some neurological condition, then which conditions will come to your mind? That means it is basically due to the neurological deficit.
Sir, first I will think of GBS.
Okay, very good.
If in this case lower limb is involved, so we can think of transverse myelitis also.
Okay,
Then peripheral neuropathy is also present like this.
okay. I think one disease
If
we
there
have,
is any history of trauma if present, then we can think of traumatic neuritis or trauma-induced
very
also.
good. Yes, Aarti said that is also possible. And I think in that case, you can go for acute or some chronic. Suppose in some other condition, child gradually developed this weakness and now not able to walk. It took some even days, weeks together for development of this whole story of not able to walk. Then which conditions will come here? And having some backache even. And on,
Sir, GBS.
and on examination, you found, oh, there is some swelling even at the back. And that swelling is also gradually developing since long. Parents may provide the history. That this is this developing since even months or years together, having some difficulty in walking, but able to walk. Now gradually,
Meningomyelocele we can think of, sir.
okay. Meningomyelocele, obvious that you are right, but in that case, it will be the even some evident or complaint from the, because it's a congenital malformation.
Yes.
Of course, but both the condition, I think tuberculosis, what brothers say,
Yes.
in our country, we should keep in mind, right? I think let us first discuss the residents or the students, then we'll go to the experts. They will explain all the details, what probably we have missed or something, and what other symptoms you will try to gather. Of course, I think Dr. Dhaval mentioned already fever or pain or other things. And now second complaint what Aarti mentioned is a decreased sensation. Then you know that the second symptom makes you very alert. What does it indicate? And that is also of short duration, same time, 1 day only. I will say it is not acute, even hyperacute, you can say.
Peripheral neuropathy.
Okay.
Suggestive of neurological illness.
Right.
So we need to be more cautious and work promptly.
I think at least you can make your mind in this way, that at least motor deficit is there, but along with that sensory issue is there.
Sensory also. Yes.
And that will help you to consider some of the conditions. Obviously, every time in our medicine not so demarcated, but of course we can take the help. And later on, even the retention. That bladder is full, but the child is not able to pass the urine by her own. What type of the problem? Forget regarding now even regarding this neurological problem, inability to walk or even sensory. Suppose if you focus on the urinary bladder, somebody can tell that what is the nerve supply of the urinary bladder?
S1, S2.
Rajat, yes, please.
So S1, S2, S3.
Yeah. What type of the nerve
Yeah.
supply?
Sir,
Sir, parasympathetic. Parasympathetic.
Okay. And is there any other nerve supply?
Hypo.
What is my idea? That for this reason, we should first know the anatomy, then the physiology, and then we can try to locate that what type of urinary bladder problem is there in this patient. That will give you some idea for the further thought process. If I remind you,
pudendal,
yes, Rajat, further,
pudendal nerves are also supplies.
okay, which type of these fibers?
Somatic nerve fiber.
Somatic nerve.
Please remember that urinary bladder has three types of nerve supply: sympathetic, parasympathetic, and somatic. Right. Now, what the sympathetic nerve supply does? What is its function?
It prevents
Sympathetic nerve supply will do detrusor muscle contraction and relaxation of bladder neck.
That means
While
emptying of the bladder.
emptying of bladder, yes, sir.
And parasympathetic?
Sir, actually, reverse sympathetic will do filling
okay.
of the bladder.
I
Parasympathetic
wanted that you let yourself change. Parasympathetic will be because the filling of this urinary bladder. So relaxation of the detrusor muscles and contraction of the sphincters. While the urinary bladder is full, there is the contraction of detrusor muscles and relaxation of the sphincter. With the voluntary control, person can pass the urine. Now here, urinary bladder is full, but not able to pass the urine. That means which fibers are affected? Which type of the nerve supply is affected? Urinary bladder.
sympathetic.
Parasympathetic.
Because you know that bladder is full. That means it is allowing to fill up, but not able to pass.
Parasympathetic.
Parasympathetic.
I think both, even voluntary, she is not able to pass the urine. And somatic fibers, I think they are by the pudendal nerve. Right? This is a pudendal nerve, probably. This nerve supply somatic fibers comes. So possible that even the parasympathetic as well as these somatic fibers are affected. Why I'm coming to that you can decide even suppose the spinal cord problem, then at what level it is possible. That will give some idea. We'll have to correlate as a whole, but I think this is just to give the idea. Of course, not pastoral also may be the part of it. Right? And then here from the symptoms, it gives the idea that it should be some spinal cord problem. Is it possible this central problem in this type of presentation?
Sir, yes, it can be. If the pons is involved, then there can be micturition issues.
Arti, you know that in this patient, child is conscious, as you say.
Yes, sir. Yes, sir.
Child has no seizures, no altered sensorium, no probably respiratory problem, because in your complaint you have not mentioned.
No, sir.
Otherwise, you must have mentioned. Right. That means it is the problem of spinal cord. At what level we'll decide later on from the examination. But suppose even these manifestations, what is my question? The spinal cord problem, is it possible due to the central lesion? And if it is yes, then where?
Neurogenic blood.
Anyway, I think now let us go to the experts so that they will incorporate all the symptoms together and they will try to elaborate in a better way. May I request Dr. Harshiti? Dr. Harshiti? Okay, Dr. Anand, meanwhile you can take it, please.
Very good evening. Here we got three cardinal features. Acute onset of weakness, acute loss of sensory loss, acute bladder problem. So everything is very clear, and we know what is the reason, because it is acute presentation with the weakness, bladder symptom, sensory symptom, maybe some lesion in the spinal cord. For discussing such a case, here our main focus of attention is that either not Guillain-Barré syndrome or transverse myelitis or anything like that. It is an acute flaccid paralysis for a PG student.
Yeah.
So we have to go to an approach in a way that how it will reach a diagnosis. For example, the here 11-year-old female. So what are the age? Means 11-year-old, what are things you can rule out? Some congenital problem you can rule out. So many muscular dystrophy, because flaccid paralysis will come either in central hypotonia or peripheral hypotonia. So starting from your anterior consulates, your nerves, myonodal junction, muscles, they should not be biased with your diagnosis. That is the most important thing. It should be open. And
I think
11-year female, so we can wrote so many congenital malformation. Dr. Dawal mentioned about some myelocele, meningocele. So all this will may present earlier. Congenital myopathies, some neurodegenerative disorder, neuromyelitis disorder. Some of them will present as a paraplegia. What are the neurodegenerative disorder present in paraplegia? Just for just a PG discussion. So such things are important. Neurodegenerative disorder presenting as a hemiplegia, neurodegenerative disorder presenting as a paraplegia, neuroplegia presenting as a quadriplegia. All this here we are getting a weakness of both of them. What are the some condition we'll get it?
Sir, it can be due to acute onset of flaccid paralysis like GBS, transverse myelitis.
No,
Or,
neurodegenerative disorder, neurodegenerative neurometabolic disorder.
Sir,
So
it can be
arginine
due to
deficiency.
Fabry disease, or
This is one like that arginine deficiency, multiple carboxylase deficiency, or some rare kind of biotin deficiency may present like that. Okay, we'll roll to that one. And then next comes the sex. It's a female sex. So what are the you can roll? What are the exclusive male get? For example, muscular dystrophy. What are the X-linked muscular dystrophy?
sir, Duchenne muscular dystrophy and Baker's muscular dystrophy.
Any other? Because that is your MBBS teaching. Now you are PG student, so you have to increase your vocabulary. One more. Emerald reflex also X-linked. So each and every point discuss like that, and here we have to find out. So here acute onset of weakness. So what are the etiological agents? Here you mentioned about one thing, some cough and fever. I don't know, cough is there, fever I am not remembering. So what are the etiological factors here? Any history of trauma?
No, sir, no history of
No history of
trauma.
trauma. No history of vaccination. That is also very important, because that will come, vaccination will come later. But here we want to see whether this child had any recent injection, recent trauma, or what are the cause. And also, if there's a weakness there, you mentioned about some weakness. I don't know whether you come to that point or not. What extent the weakness? A single limb first, both limb, same side, upper limb. What about his consciousness?
Sir, weakness was both limb involvement simultaneously. Initially, father has noticed that few movements were present in toes, but within few hours, child was unable to move the limbs completely. So it was symmetrical, and child was able to move upper limb, so there was no involvement of upper limb.
So from this day, 2-3 days now, it is 3 days. Whether it is ascending or descending, okay, it is ascending. But whether it is ascending further,
No, sir. There was no any ascending kind of pattern.
yeah, you have to mention all this, and also whether it is a static, any respiratory system involvement, because any difficulty in breathing. Because if I concerned with all these things, is that GBS, whatever it is, one is bladder, second is respiratory. Is there any involvement, difficulty in breathing? If she got any problem in getting respiration, something like that also, you have to mention. And of course, I think history not complete. I think it just started. So I wait for history for further questions.
And just we have started the symptom. I think still her history is incomplete. She will go in the details. So I think Dr. Harshiti, anything from your side before we go further?
Hello.
Please,
Okay,
please.
I was just thinking that whenever such patient comes, what do we see? We see the
Right.
weakness, right? Whenever there is a weakness, our first aim is it unilateral or it's a bilateral? That is the first thing to be seen, and whether it is an acute or it's a chronic one. These are the two things which we always take into the account. And when we think that it is an acute or it's an subacute, when it is an acute, yes, the etiology would be either the infective or an infection or a trauma or an ischemia and something like that. But when it is a subacute, there is always a dilemma that whether the child is having what could be the other reasons, because it is not only the infective etiology which takes place, but there are something else beyond that which we have been discussing in the few minutes. So what is important for the residents is to identify, is it a real weakness or it is said to be the weakness? Because many a times what we have seen in the practice, the patient complains that child is not able to walk. But if we see them, the power is good. So in those cases, first thing to be seen is to evaluate the power first, then the tone, and the tone is always relevant.
Madam, Dr. Harshiti, I think still she has started the history part, only 2 slides. Rest of
Okay.
the points I think we'll get on further development of the case.
Okay, so what we would like to see is an weakness. Is it true weakness or it's a false weakness? And second is an acute or subacute?
Right.
That's what I would suggest.
Absolutely. Thank you very much. I think, Aarti, you can take it further, the history part. We'll complete it and then again we'll be back for the discussion. But what I think both the experts explain us, that always try to first differentiate that not able to walk is really in the true sense weakness, that is neurological, or really due to some pain or other reason. And then try to find out is acute, subacute or chronic. And then acute, then also you can try to find out at how it started, and that too unilateral, bilateral, was it really static or progressive? And that information will provide you idea for further thought process. Of course, as Dr. Anand was pointing out, that fever or other cough or something, some viral infection, if it was there, what was the significant, what was the interval between this problem and this neurological, all this information in short in the history will try to derive. Okay, you can go further.
So negative history. There was no history of fever or breathlessness, no history of nausea, vomiting or headache, no history of IM injection recently or no any vaccination history, no history of trauma and fall, no history of similar complaints in past, no history of drooling of saliva, double vision, paresthesia or weakness of face, no history of dog bite.
I think again we'll forget it. So Aarti, for a while, can you just stop sharing, because these negative points are very important.
Yes, sir.
And therefore, I have taken the, I will say short so that I cannot forget. One by one point we can take it. She said there is no history of fever. But what is the importance of fever in this case? How it will help us for further thought process? Its presence or absence?
Sir, with fever, we can think of infective etiology. It might be viral, it might be bacterial, but we can think of any infective or inflammatory origin of disease. So,
Can you give some names that this condition can present with the fever, and this particular even present without the fever also? Can you give some examples?
sir, in case of GBS, there might be history of fever. In case
Okay.
of TB spine or something.
That fever at the time of presentation, at the time of neurological deficit, are you expecting fever in the case of GBS?
Not at time of, but there is a history of a fever
Okay.
prior to the illness.
Okay, okay. And that fever is commonly due to what?
The respiratory or any gastrointestinal infection.
Very important, very important. You know, that can be due to some antecedent respiratory infection or even GI infections. Later on, the patient may come with this neurological deficit like GBS. So history of fever is important in that way, of course. And then what is the no history of breathlessness she wants to clarify why it is important in this patient.
Sir, in case of any progressive neurological deficit, if respiratory muscles are involved, then there is a difficulty in breathing and something. And other thing we can think of any respiratory origin of infection to look for that.
I think with the reference to the neurological presentation, what is the importance of difficulty? I think Dr. Anand made the point. Dr. Rajat?
So it basically signifies the progression of the weakness
Yeah,
and the
And-
severity of the illness.
yeah, absolutely right. That suppose in a case of GPS, even always you should be careful also while monitoring. That respiratory problem starts, it indicates involvement of respiratory muscles. And even the severity of the disorder, you can plan even for management also that patient may require some ventilator support or something. So that's vital point. Nausea, vomiting, headache. Arti, what was your idea?
Sir, to rule out any central nervous system infection or meningitis if it is present.
Okay. One thing I would like to remind, if the vomiting is due to the CNS cause, nausea is usually absent. Absence of nausea and salivation and vomiting is present. Probably that indicates CNS origin. Okay. Intramuscular injection, trauma, probably self-explanatory. Similar complaint in past, is it possible that suppose the patient recovers and then again presents with the same this type of the presentation, recurrent problem? Which conditions and suppose?
Sir, in
Demyelination syndrome.
Yes, one by one. Dawal, yes, carry on. Aarti must be well prepared.
So if there are demyelination syndromes,
Yeah, like what I mean to say that child develops suppose weakness of both lower limbs or something. Whatever the condition you diagnose, treated, recover. Again came with the same presentation. So what is my point? That which disorders are known to present in this fashion, the recurrence? Are there any?
some multiple sclerosis.
Okay, Aarti, how much it is common in children? Multiple
Sir,
sclerosis?
very rare actually.
Okay, but it can occur, recurrence.
Yes, sir.
Then we'll go to the experts to learn. Any other condition?
so certain toxicities are like they will peripheral neuropathy usually they present with like arsenic toxicity, chronic
Okay.
exposure to certain
Even I
toxins.
will say routine conditions commonly, if I say whether GBS can recurrence of GBS is known.
Yes, sir.
Yes.
Okay. Dr. Anand,
Partially
Dr. Anand, can you take this point?
Yeah. And
Recurrence.
now you mentioned about the headache and vomiting. What are the CNS cause for weakness of the both lower limbs?
Yeah, central, I think we talked.
Central
Now
cause for
explain.
this one. Not very common in children, but what are the central nervous system causes? In say CNS inside brain will cause weakness of both limbs.
sir, stroke.
Stroke will get a hemiplegia. Which type of stroke? Single angial cerebral artery stroke. You make it parasagittal meningioma. Such a condition will get a low in B. Very rare. Okay. Headache and vomiting. And next question, there is no history of similar illness. What are the conditions get similar illness in the past?
Yeah.
Sir, neuromyelitis optica or multiple sclerosis in which there is remitting, relapsing conditions. Though which these conditions are rare in children, but it can be possible. Sir, even in emoji also the initial presentation can be like transverse myelitis and child may further develop to.
We are dealing with the, so you can think about myasthenia gravis. You got episodic, you are getting periodic hypokalemic paralysis. Such things will be recur and come and go.
Yeah.
Dhaval, can it be poliomyelitis? Because when myself and Badr Pradesh have seen lots of cases of poliomyelitis, the
Yes, yes.
polio is not there. When was the India eradicated the polio? When was the last case in India? Last case of polio in India, because we are proud of eradicated polio. So when was the last case and when India declared? I just want to hear only.
Yes,
Just
yes.
to aware about this one.
2011, sir. Last case was in 2011. The polio was eradicated after 3 years of the last case.
Yeah, can it be poliomyelitis this one?
Sir, if it
Poliomyelitis, any type of enterovirus may produce a weakness. Enterovirus. That is why we are asking about polio. Okay.
Please remember from the exam point of view, as Dr. Anand said, acute flaccid paralysis is very important topic. And polio point of view, please remember, last case reporting and India is polio free. Still, we are not eradicated. So that the differences we'll have to know. Anyway, Dr. Harshruti, madam, can you take it further? Any recurrences
sorry,
of
yeah.
this kind of presentation?
Yeah, I was just going to tell because Anand sir previously mentioned that there could be some metabolic disorder which can present with an acute
Right.
weakness.
Yes,
So what
yes.
we have seen in our practice is there could be acute metabolic decompensation following a febrile illness. And this we have seen in a patients with even MSUD, even with biotinidase deficiency who presents in a late age group where we have to, because even in the botulinum toxicity,
Yeah.
because we have seen this in the practice that we get biased with the idea of GBS, NMO spectrum disorder, but these are the conditions which are usually missed if we do not see. And for that, we have to keep this in the mind. And whenever there is an recurrence, apart from recurrence of GBS or a stroke, we should have something in our mind regarding these conditions.
Absolutely fine. I think good points and better to keep in mind that these conditions common may be in your mind, but when you face the problem, I think better to keep in mind these metabolic disorders which can present in this way. Anyway, I think good points have been taken. Arti, now again you can share your PPT and please complete the history part. I thought that it is said that the history is more important in any CNS issue, as a whole in the medicine, more so in the CNS.
there was no significant past history or no history of any medical comorbidity or hospitalization. This is first by birth order. Child is born of second degree consanguineous marriage and no significant family history or any major illness in the family. Antenatal history, child is first born, no significant antenatal, natal or postnatal history. Routine antenatal visits were taken. First trimester, no history of fever or rash. Folic acid was taken. No history of any drug intake or radiation exposure. No alcohol, tobacco, or substance abuse. Second trimester, 2 doses of tetanus were taken. Iron and folic acid were taken regularly. Anomaly scan was done in which no abnormality were noted. During third trimester, fetal movements were well appreciated. Adequate weight gain was there. No history of fever or UTI. No bleeding per vaginum, false smelling liquor or premature rupture of membrane. Child was full term, normally vaginal delivered. Hospital delivery, cried immediately after birth. Birth weight was not known. No history of an ICU stay. Breastfeeding was started soon after birth and child was exclusively breastfed for 6 months. After that, complementary feeding was started. Immunization history, though there were no documents were available, father was saying that they have taken all the vaccinations according to NIP schedules. Last dose was taken at 4 to 5 years of age. BCG scar was present. Developmentally, child is studying in 9th standard. Good scholastic performance, age-appropriate peer behavior, and normal hearing and vision. Dietary history, there is a calorie deficit of 300 kilocalorie per day and protein deficit of 8 grams per day. This belongs to upper middle class of modified Kupuswamy scale, staying in 2 room with kitchen with private toilet, 6 family members with good ventilation. Father is laborer earning approximate 8,000 to 10,000 per month. So, should I go with the summary?
Yes, I think, but summary should be in some other form.
Okay.
Not the repetition of the same story which already you have described. But you should go for your interpretation, your hypothesis, that what type of problem you are thinking. Always try to think in CNS, what is the likely anatomy? Where is the problem? At least from the history point of view. And then what is the pathology? And etiology, at least you can put forward possible or multiple. So point is how you are going to interpret this history part. You can put, I will say, description in short and then possibilities. Try to at least put in that fashion, Aarti.
Okay, sir. So 11-year-old female presented with acute onset of bilateral symmetrical lower limb weakness with sensory loss in both lower limb with bladder dysfunction without significant progression to involvement of upper limb with history of some viral illness with which is 20 days back without any history of trauma, blurring of vision or similar past history. So this history is suggestive of rest of the things, sir, antenatal, natal, postnatal and developmental history were normal. So this history is suggestive of mainly the case of nervous system involvement, probably due to spinal or peripheral nervous system, mostly with post-infectious etiology.
Okay. Anybody would like to make one more attempt to put the summary in the, I will say, fashion or format what I say? Rajat, can you do it?
Yes. So here we have a 11-year-old female who has presented with acute onset lower limb weakness, both involving the motor as well as the sensory component, with probably autonomic component as well in view of bladder dysfunction, non-progressive in nature, and most commonly secondary to viral etiology.
Okay, good attempt. Anybody else? I think what I want to convey that as Dr. Anand was pointing out, as we grow as a postgraduate, we should try to develop some important skill that how you can convey the message. Already, I think history is described. We have discussed at length, even we try to interpret it exactly. Now, from this interpretation, we are trying to derive that what is the likely our hypothesis regarding this disease process. From history only, we cannot come to the conclusion. It is just our thought process, which may be changed even on examination and further investigations. But how we can put it, that here 11 years old female has presented with acutely, that is number one is very important. It's a acute, it's a non-progressive, involving both lower limbs weakness. Along with that, there is the bladder dysfunction also, and even the sensory system involvement. With the absence of the other symptoms in the form of the CNS involvement, it is likely that it is a very classically peripheral nervous system problem. From the peripheral nervous system problem, particularly the weakness and bladder involvement and sensations together, it is more possible that involvement of the spinal cord. And then it should be somewhere at the thoracolumbar region. That is the anatomy. Now, having this acute history, this is possible that maybe and there is no history of trauma or anything, probably some following some infective or some immune mechanism is possible. But of course, we have to keep in mind even some immune mechanism or even some vascular etiology also, because vascular etiology can also present acutely. And as it is the first time, in the absence of recurrence, the conditions presenting as the recurrent are less likely. And therefore, you can consider that the spinal cord problem, either the post-infective or with the vascular involvement, this is more possible. Right. So I think you can put forward this type of the hypothesis. Okay. Dr. Anand, should we go for examination?
We want two more important details. One is you mentioned about and no rolling of saliva, no facial, something like that.
Yeah.
What are the client now commonly involved this condition, such a condition? You mentioned about diplopia. What else you get? What which cranium will you, for example? So which cranium will you involve there? You think about optic nerve also.
Yeah.
So you
Absolutely.
not mentioned about diminished vision like that. You not mentioned. You mentioned about diplopia, but you not mentioned any diminished vision.
Yes, absolutely.
like
Very,
that, you
very
are not
important.
mentioned.
On
And
the
another
contrary,
thing is
any
that,
demyelinating condition, then optic nerve involvement is very common. Yes, sir.
Yeah. And the second thing is that family history. Family history, you have to mention about no significant family. You have to mention first child, second child, male, female, any death, any sibling death. And also, of course, you have to mention tuberculosis here.
Yeah.
Yeah, you know, family issue tuberculosis actually very important here, because how can we, in India about tuberculosis, weakness of both the lower limb in acute onset. So you may get a tubercular abscess or something like that, you may get it. So
Yeah.
you under detailed family history rather than just like what you have mentioned. I think detailed history is needed in case of neurological case.
Absolutely.
And the immunization history also, BCG scar is present, okay. What are the immunization related problem? How are immunization related to such a presentation? So some immunization will protect against weakness. We already mentioned about polio. Then some immunization produce weakness. Which are the vaccine produce weakness?
DPT vaccines are hypo-responsive event.
Yeah. No, that's something
Sir,
different.
COVID.
Hypertension is something different. And yeah. Then you'll get a rabies vaccine. And even though we are
COVID
nowadays
vaccine,
using
rabies
newer
vaccine.
derivative, MMR vaccine, you get a very notorious for demyelination.
Yeah.
And vaccine against diphtheria. Diphtheria will produce. What are the neurological complications of diphtheria?
Cranial neuropathies.
Should be
Then
specific.
What is the common presentation?
Three types of neurological weakness in diphtheria.
usually the low bulbar the 10, 11, 12.
Okay. So start with the problem of cranial nose involvement, particularly there may be the nasal twang, nasal regurgitation, difficulty in swallowing, right? And later on even may go for the weakness and even the respiratory involvement. So that is the thing. But most common presentation of post-diphtheritic polyneuritis is either the nasal twang or the nasal regurgitation and even the difficulty in swallowing. And then you can get all these other manifestations.
Regarding sensory complaint, you are not gone very means bilateral symmetrical. You mentioned about it. That is sensory symptom or sensory signs, and any definite upper level means area of hyperesthesia. Your examination you can elicit, but you can ask the patient a tingling sensation, something like that, tightness, something like that. Also, you can mention in the history. Also, you can mention like that. There are some points. And what about you mentioned about nutritional history? Okay. What is the relation between nutritional disorder and such a type of weakness? What are the nutritional deficiency associated with weakness?
Pyridoxine deficiency B6 can present with peripheral neuropathies, sir.
Okay. I think is there
Then,
any, Rajat, if I give the hint, what I'm sure that Dr. Anand must be interested, any nutritional deficiency which can involve you the spinal cord and this type of the involvement?
Vitamin B12 subacute combined.
Yeah.
That should come first.
That should come first. Yeah.
And the beta is not uncommon in our setup. So
Yes, absolutely.
So when you are saying, you have to be keep in mind all these possibilities. When you are saying development history, when you are saying dietary history, nutrition, any part, on direct physical contact, we can interrupt any time. Since it is an online class, myself and the Prajavis are not interrupting you too much. But if it is a physical class, during each history, we'll ask questions.
Yes,
You ask questions. Okay. Next.
Yes, Aarti, you can go for examination.
General examination. Patient is well built and well nourished. Temperature was 98.7 degree Fahrenheit. Pulse rate was 98 per minute in right radial artery with good volume. All peripheral pulses well felt without any radial or radiofemoral delay. Respiratory rate was 27 per minute, regular with thoracoabdominal pattern. BP was 102 by 70 mmHg, which was between 50th to 90th centile, which was measured in supine position. Saturation was 97% on room air. There was no history of no pallor, icterus cyanosis or lymphadenopathy, no clubbing or edema noticed.
So you have to mention something more about BP.
Which was measured by palpatory method, sir?
No, postal hypotension, autonomic regulation. You have to think about such a postal fall of hypotension, autonomic dysfunction. It is a Guillain-Barré syndrome, other condition you get. So you have to post, in supine position, you have to postal way. Autonomic nervous system is affected. So better to say that any postal hypotension, something like that, because it will happen. Autonomic system is there. So you have to look at that one also. Okay. Carry on.
On head-to-toe examination, head size is normal and normal shape. Hair examination normal, no facial abnormality or dysmorphism. Eyes, ears, nose examination was normal. No any abnormality in mouth or oral cavity. No neurocutaneous markers noted. Neck examination was normal. Limbs were normal. Genitals normal with tenor staging 2. Back and spine normal.
So what are you expecting head? Will you get a weak, lower limb weakness in a condition, head, a large head, something like that? What will happen to in hydrocephalus in lower limb?
Hypertonia.
Hypertonia.
I am asking about it. I know the age is something different, but for discussion purpose, if a child with hydrocephalus, what will happen to?
Sir, hypertonia, if there is hydrocephalus.
No. There won't be alteration of the tone, but there will be a weakness. And he is asking about the weakness which you get in hydrocephalus. Because with the hydrocephalus, there will be widening of the ventricles. So the ventricle will that will compress the brain tissue around them. So that area is known as a periventricular space. So there will be involvement of the periventricular region. So what are the threads which are going through periventricular region? And if they are involved, what kind of weakness you will develop?
What is diplegia? What is the mechanism? Just an example. Again, periventricular region is affected, you will get a spastic diplegia. Yeah, madam, just mentioned about the ventricular dilatation, everything, which fibers will be affected. In hydrocephalus, where will get excited reflex and everything. You may get a both upper limb and lower, but it will be more in the upper limb, lower limb. So that is regarding head size and shape. So
and the second thing is the glutaric aciduria type 2 can also present with the weakness when there is a large head, which one has to keep in the mind. The large head matters. Yeah. Third thing is sometimes the MPS in the long run can also present with the weakness, but it is always a chronic onset. So they also present with the macrocephaly. These are the things which presents with the macrocephaly.
Glutaric aciduria, you will get the specific some facial features also with the large head and motor deficit.
Yes. Even I have seen the patients with a vitamin D resistant ricket presenting with diplegic state, and the diplegia.
Yes. Okay, Aarti, go ahead. I think what you mentioned, dysmorphism, this is more important what Madam Dr. Harshruti mentioned, that in a case of even glutaric aciduria, MPS or some other varieties, even they will present with the dysmorphism. And along with that, if you get this weakness or something, you can correlate that these conditions are possible. So the point is what experts want, that go very meticulous examination, try to note it, and what is the significance of it with a very specific condition that we will try to correlate. Okay.
So that's a relevant history.
Yes, absolutely.
On examination, height is 137, which was between 10 to 25th centile. Weight was 28 kg, which was 10 to 25th centile. Head circumference was normal. BMI was 14.9, which fits between 10 to 25th centile. Upper segment, lower segment ratio was 1:1. Mid-parenteral height was between 10 to 25th centile, and these are the growth charts for this patient. Sir, should I continue with nervous system
Yeah, I
examination?
think you can take this nervous system, and I request both the experts to focus on the nervous system examination, and you can take it later on. Arti, you can start it.
On higher mental function, Glasgow Coma scale was 15/15. Child is conscious, oriented to time, place, and person. Speech and memory was normal. During cranial nerve examination, in first cranial nerve, child is able to appreciate the smell. In second cranial nerve examination, gross vision and visual acuity was normal. Pupillary reflex were normal, and fundus examination was normal. On 3, 4, 6 cranial nerve, pupils are normal in size and position, reactive to light, with full range of ocular movements noted. On 5th cranial nerve, bilateral corneal and conjunctival reflexes preserved. Jaw jerk were normal. Sensory and motor part was normal. On 7th nerve, bilateral facial symmetry was there. On 8th cranial nerve, Rennie's and Weber test were normal. Romberg test I couldn't perform, sir. On 9th and 10th cranial nerve, uvula was centrally placed with symmetry, and on 11th and 12th cranial nerve, examination was normal.
So just to forget about this case, what are the information you get from eye examination in a case of neurological deficit child? What are the information you get from neurological back, one slide back?
Yes, sir.
So just for this one. So second nerve, what is important second nerve examination in the case of neurological disease? I am not saying about your weakness of a lower limb. What are the information from first anterior chamber to posterior fundus? What are the information you get? First,
Sir, with fundus examination.
not of fundus, everything from a complete eye examination.
So, Arti, what sir wants that what is the importance of eye examination in these types of cases, not in this particular case, and which each finding, how will correlate that this is likely with this particular condition. Not only fundus, as a whole you can take it.
Yeah. For example, abnormal standing of eye, Down syndrome. What type of weakness will get in Down syndrome? What type of paralysis after 4 years?
I think, Anand, Dr. Anand, for the sake of this discussion, Arti, can you just stop sharing for a while? Because sir has taken the very important question. I'm sure the exam is going to be useful. So participate all the students. What sir wants, that eye examination, various findings with the CNS disorders, which you can correlate with a specific condition. Take one by one. Yes, Dhawan, you can start it. Give some rest to Arti. Dhawan?
So like,
Yes, Rajat, please. Very good. Good
So
beginning.
so if we have an acute onset of vision loss, then most likely it can be a problem in the optic nerve, such as optic neuritis.
Okay.
Then based on the defects, whether it is a bitemporal hemianopia, binasal hemianopia, the quadrantopia, so we can localize the lesions as along the tract of the optic nerve from the from the eye till the brain, like along the tract where the lesions can be localized.
Okay.
Then based
we
on
can
the
start-
pupil.
So you can start from the external examination from planning. That is how you asked what complication, neurological complication you get in Down syndrome after 4 years. You get so many neurological complications. You get a hypotonia, you'll get a mental, everything will get it. But after 4 years, which particular complication you get?
So in Down syndrome, the children are prone for hypothyroid. In that case, extraocular muscle weakness we can get.
That will get very early, after
Okay.
4 years. At least it's a dislocation. You get because of the short autonomic segment. And after 4 years, when they start to playing and they contact sports, you get this one. So you get a quadriplegic presentation. So from and you can get hemorrhage. You see subconjunctival hemorrhage, A beta lipoproteinemia. You may get features of say vitamin deficiency, attack, something like that. Then you have to go further. You have to see the lens dislocation. For example, homocystinuria, you'll get stroke
Homocystinuria.
and like that. Then you get further back, you make the optic neuritis. Then you further back, you'll get retinitis pigmentosa, or you make some pigmentation. Or as Madam just mentioned about rotary aciduria, you make it from bleeding. So yeah, very, very important. The examination of fundus is very important. From first, from the to eyelid, eyelash to backward. So you have to see a detailed presentation. You should know not only this case, any case of development delay, any case of suspected intrauterine infection, cerebral palsy. So make it a habit like that. You present exclusively from eye examination is very, very important. Unfortunately, we are not using our fundoscope very frequently.
Yeah.
We are just referring to ophthalmologist. So you have to use fundoscope, ophthalmoscope regularly so that you can make a habit like that.
I think what
Okay, sir.
Dr. Anand wanted, that in the exam somebody may ask you the importance of eye examination in CNS problem. And I think in that case, we should be able to answer properly. You know, in some patients, you will get even the cataract, or on follow-up also you should examine. Many a times with the development of focal seizures or even the delayed development, if you examine, you may get cataract in a case of galactosemia, even at the early age. Right? Even you can give this cataract in a case of oculorenal cerebral syndrome also, what we say Loewe syndrome, which will present with the different conditions in neurological also. Even you can examine the growth spots also in a case of tuberculosis. Even in a case of bacterial endocarditis, you can get it. Even the cherry red spot in a case of Tay-Sachs disease, which will present with the neuroregression. So what actually sir wanted, that so many points and salient features we should be able to answer. And you know, it becomes the very characteristic to catch the diagnosis. That's why sir is asking this question, and it is very relevant. So please remember importance of eye examination in neurology. As a whole, we should know. Of course, besides all optic neuritis, papillodoma, and so many things. Is it okay, Dr. Anand?
Then also nystagmus, subcutaneous myoclonus syndrome,
Yes.
everything is important. Each and every aspect
Absolutely,
of eye
absolutely.
exam is very, very important.
Just what is his idea, that just that finding, that your sign will catch the diagnosis. If you get the someone opsoclonus, very immediately you will think that, oh, it's a neuroblastoma. So the point is, sometimes you are not able to get the reason, but if you get it, then it helps a lot. I remember that proptosis, I was thinking for the scurvy or something, but when I got that there is a mass in abdomen, turned out to be the neuroblastoma. Obvious examination was eye examination. Proptosis and I would say orbital, there was the bleeding. So this is the point, that how it should be kept in mind.
I think many students are writing answers, very right answer in the chat box. Why can't you open the video and you can help Aradi and Dawal?
Please answer.
You open, you are giving right answers. Why can't you open Edward and other things? You can open the video and you can share the knowledge with us.
Yes.
Okay.
Okay, Aarti, go ahead.
Motor system examination. Bulk of muscle was normal, no muscle wasting or atrophy noted. The muscle girth on both sides are equal and normal in size and shape. Tone of both upper limb was normal, and in both lower limb, hypotonia was noted. On power, shoulder abduction, elbow extension, and wrist dorsiflexion was 5/5 in both upper limb. In lower limb, hip flexion was 0/5 in both limbs. In knee extension, it was 0/5, and in ankle dorsiflexion, it was 0/5. Downwards. On reflexes,
0/5 according to which staging, which grading system?
sir, MRC power grading system.
Okay. So here you are getting upper limb left. You mentioned power, which you will take a power of all the muscles in upper limb for grading. Which are the muscles not graded in upper limb? You mentioned about shoulder, elbow, and wrist. We not take power of small muscles of the hand.
Yes,
We
sir.
not
We can
consider
also
small
ignore.
muscles of the hand, trunk muscle, neck muscle. We not consider for the grading. And tone, you are getting lower limb hypotonia, upper limb. Okay. I hope that you know how to see bulk, how to examine bulk, how to do examine power, everything. I think you know. You have to do individual muscle rather than a joint. So examiner will ask me how to test the abductor. You mentioned about knee extension, dorsiflexion, but you not mention any adductor muscle or abductor muscle in the lower limb. So which nerve supplying abductors in the adductors in the lower limb?
Adductors.
Sir,
So you can expect questions any stage. We can interrupt any time because
Yeah.
you mentioned about this one. So what is hip flexion and knee extension? Which muscles involved in hip flexion and knee extension? Such a question. So that's a question. Also you can expect which nerve is supplying this one. What is root value of nerve? Everything they will ask. Okay, sir. I think you can.
Yes.
on superficial reflexes, conjunctival, corneal, and gag reflex was normal. In abdominal reflex, the abdominal wall contraction was noted above the level of umbilicus, but it was absent below umbilicus. Bilateral plantar reflex were absent. On deep tender reflex, biceps and triceps reflex were +2 in both right and left upper limb. On supinator, it was +2. Knee and ankle deep tender reflexes are absent.
So why you omitted jaw jerk?
Sir, it was actually I mentioned in cranial nerve, but I should mention in superficial
Because
reflexes also.
we teachers have bad habit. We'll find your fault very quickly without any problem. And what is the root value of cremastic reflex? You not mentioned here only the female. What is the root value of cremastic reflex?
Sir, S2, S3.
Cremastic, that is too low.
Alpha S1.
Alpha S1 is right.
L1, L2, sir.
It's L1, L2. So,
L1, L2.
no, means examiner can ask root value of any reflex, any segment. So even they can ask, because here you not mentioned about the anal reflex, interscapular reflex. We can ask some other reflex also. You are a PG student. MD pediatrics is the highest degree in India in pediatrics. So we can ask any questions to you. So you should know root value. It is simple questions. So all these things. What about angle jerk? Any idea?
Sir, ankle, sorry, sir.
Ankle jerk root value.
Root value.
Sir, L5, S1.
S1, S2, sir.
S1 S2.
Yeah, it is. It's not the help by L1. So
It
should
is
be
S1,
thorough
S2.
about all the reflex and how to elicit also very important because we are now it is not possible to elicit it, but you have to know how to elicit also.
Even at the one point which you have shown over here in the figure regarding the abdominal reflexes, the direction is not right. For upper one is okay, but for the lower reflexes, this is not the direction. And even middle one also you'll have to show. You know, the above the umbilicus, at the umbilicus, and below the umbilicus. So that is number, at 3 points we examine. And for examination of the direction, upper one is right, that you will come from upward to downwards towards umbilicus. But from the lower, you will go from different directions. So please keep in mind.
Arjun, what is your inference here? What are the conditions you will get the loss of abdominal reflex? And what is the inference here?
Yeah.
In the particular case. So you
So, sir,
beautifully drawn a diagram. So you shown upper part positive, lower part negative.
I think, Dr. Anand, just I may request that later finish the examination, then we can go for the positive findings.
Definitely,
then,
sir. Definitely,
then
sir,
probably
definitely.
exactly the anatomy.
Yeah.
Okay. Arti, you can complete your examination and then we'll go for the positive findings and anatomy.
okay, sir. On sensory system examination, superficial sensations were normal above the level of umbilicus, which was touch, pain, and temperature. Child was not able to localize below the umbilicus. On deep sensation, pressure, position sensation, and vibrations were normal above the umbilical level and unable to localize by child below the umbilicus. And for cortical sensation, 2-point discrimination, child was able to differentiate 2 points and she was able to recognize the object. No signs of meningeal irritation. Cerebellar signs were absent. Head size was normal in shape and size. No congenital malformations. On spine examination, no tenderness or deformity were there, and no abnormal involuntary movements were present.
Okay. Anything else on CNS?
No, sir. Other system examinations were within normal.
Okay. I think now you can stop sharing. I request Dr. Anand or Dr. Harshiti to take the point regarding the findings, positive findings for examination, and then try to localize that, where is the anatomy, and then you can go further.
I just wanted to ask one question because I didn't get that in the history.
Yes,
Was there a history of an abdominal pain?
No, ma'am. There was no history of abdominal pain.
Because you are presenting that there was a demarcation of the reflexes and the power at certain level, and usually in such cases, and there were sensory changes, so usually you get a history of the abdominal pain at the area where there is a demarcation. Say you are having a reflexes absent below T10, so you will have a pain between T7 to T10, and that will point out your level of lesion. But did you ask them positively? No idea.
Ma'am, on per abdominal examination, I asked them and I examined also. There was no tenderness or anything.
Because it lasts only for a day, and that's why. Anyway, okay, fine. Anand, you can carry on. Anand is there, no?
Yeah. Dr.
Okay,
Harshiti, is it at the abdominal pain or pain at the back for demarcation of the...
Sir, it is a demarcation and it starts like it's a circumferential region.
Circumferential region, yes.
Yeah, it's a circumferential region.
Right.
The area of hyperesthesia, you will get some tingling.
Yes.
Yeah, that you can get on examination, that at the level, below the level, and above the level. But as Madam said, that there is a circumferential pain, you may get the history, and that may remain for the very short time. Absolutely right. Yes. Dr. Anand, I think you can take it further, that what are the findings of the CNS, and then they can build up the case, what is the anatomy, and then further discussion, please.
Yeah. So you got here level around, so what's sensory level? What you got it here? We are abdominal reflex.
I think Dhaval and everybody should participate. Dr. Sangeeta is there. Please, everybody.
T10 level.
So you will get a definitely dermatome.
Please
So
keep
which
your
is-
video on. Keep your video on.
Cervical, you'll get a different area supplied. For example, C1. C1 is supplying where? C1 supply where? C1. This is always a
Meninges.
C1 is supply which area? C2 supply where? C5, C10. So it is a usual question we'll just ask her. So here you are getting a thoracic level at a umbilical level, which dermatome you are expecting?
Sir,
T10.
T10.
Yeah. So your reflex pattern also, your power, tone, everything is correlating with that one.
Yes, sir. Yes, sir.
Yeah. So anatomical lesion we got comparatively good means around the spinal cord, around the T10. Now what about the etiological diagnosis and what are the pathological diagnosis you have to think about? That is our idea, next one. And each and every point, exam will ask about how to elicit all this one. And also, you mentioned about a 2-point discrimination. What is sensory inattention?
Sorry.
Oh, I'll ask somebody, Rajat, what are the cortical sensation? Here it is a peripheral weakness, I agreed. What are the cortical sensation?
So one is 2-point discrimination, then stereognosis,
So graphesthesia can also
Yeah,
have been,
graphesthesia, and
yes.
stereognosis.
Okay, what is sensory inattention? I don't know any other name. We say sensory inattention. I will examine 2-point localization. You know what is 2-point localization?
Sir, we'll point out to different and ask the child whether she is able to differentiate these 2 points.
Yeah.
That is 2-point
What
discrimination.
about sensory attention? So you have to touch both areas, simultaneous area, both shoulders, both back legs simultaneously. The patient recognizes only one side. That is the sensory inattention. So that things also you have to keep in mind. And here, what about the etiological diagnosis here? Possible.
So
This
this
is
is
acute
most
onset. What are the acute or compressive or non-compressive or acute onset or chronic onset? Here we got acute. What are the cause for acute onset of weakness?
I think before that, can you focus on the pathology?
Yeah.
As commonly we say, it is
Yeah.
really traumatic, it is the vascular, it is really inflammation, it is any space occupying lesion, it is any neurometabolic. I think try to decide at least some group. And in that group, you can consider some various possibilities. So who will take it? Dr. Rajat, can you take it? That from this history, what is already we have discussed the findings also. Anatomy we decided. Now from that, what is the likely pathology? Is it some vascular lesion? It is SOM, it is neurometabolic, it is inflammatory.
So based on the acute presentation,
Hmm.
space occupying lesions is unlikely because the history would be a chronic progression.
Okay.
And the space occupying lesion in the spinal cord, usually based on where the tracts, the different presentations we would get as the compression of the tract occurs, either from the starting from the center or from the periphery. The order would be like involvement of the bladder would be later if means there would be a certain gap interval between the progression of the symptom, not in a acute way.
Sorry,
But
Dr.
if there
Rajat.
is a SOL
Yeah.
and it's a cystic, and if suddenly the cyst burst, or if there is a sudden burst of an hemorrhage, how they will present? They always present is an acute onset.
I think
And
Madam has
they
asked a
usually-
very good question. May not
And
be
there is a
common
level of
in
demarcation,
pediatrics.
so it could be an SOL. Yes.
That suppose some SOL is there, may not be having the much neurological manifestations, but once presents with a complication, even sometimes infection, or
Yes.
sometimes hemorrhage,
Yes.
and then it will present to you the acutely. In
Mhm.
that case, how will you consider or will think? That is the question from Madam. And I think it's not uncommon, not even daily or practice being pediatrician, but
But
certainly.
we have seen, we have
Yeah,
seen such patients.
Certainly. Yes, Madam, I agree. So, and another thing, Dr. Rajat, when you talk in the spinal cord tumor, please keep in mind that it can be intramedullary, it can be extramedullary. In extramedullary, it can be intradural, it can be extradural also. And then what are the various normal anatomical structures located in each compartment and which are common to known present with the various tumors in pediatric practice. If you have this idea, probably you can discuss with various tumors, and then according to the anatomical location, the presentation will be there. Neurological manifestations will be accordingly. So who will take it? Rajat, you can take it further with the question to Madam.
So regarding the tumors,
Yes, sir, please go ahead. Whatever you know, no problem. Experts are there to correct us.
so regarding the spinal cord tumors, I don't have much ideas regarding the various types, the intramedullary, extramedullary.
Rajat, I think it is not expected, so don't worry, but I will take you one by one. Suppose intramedullary, what anatomical structure will be there, which can even cause the sometimes tumor? There is
Ependymoma.
very good. Because there is the plexus, so ependymoma, if at all. I think maybe the uncommon others, which probably we may not bother, being the general pediatrician, but intramedullary, suppose extramedullary, but intradural. Which structure will come? Meninges will come. So you may get the meningioma.
Mhm.
And if you get the even extradural, then the various structures like nerves or even the fat, so you may get the lipoma, you may get even the various structures, even the neuroganglioma. So, these are the things anatomically how, and then how they will clinically present according to the anatomical location. And one very important point what Madam said, that suppose if it is a cystic swelling and it goes for the complication of either infection or hemorrhage, it will present acutely. But then how you will try to locate it? That was the question from Madam. Anybody can take it. Dhawan is silent. I think he's thinking.
No, sir, actually, spinal cord tumor, I don't know much about it.
Usually they present as in GBS because the onset is, though it is said to be subacute, it usually presents within 24 to 48 hours. So what happens is when the first person who sees them will always find that this is a subacute onset of GBS, and that's the way it goes. But when you see them, what is important, sir said, very truly he said, it's an intramedullary, it's a next. So what you find is a difference in the reflexes. The reflexes will be exaggerated in these cases, even though it is an element type of lesion, and that will point out that this is not a GBS and it's something else. So it could be SOL, and specifically when there is a demarcation of the lesion, it's a very typical T10 level. So there could be a tumor below the T10, and that can present like this. So always when there is a demarcation, it could be SOL. And there could be a syringomyelia, which can also present when there is an acute presentation of a dilatation. When there is an acute dilatation, it can present with an acute flaccid paralysis. So even the Dandy-Walker syndrome in the type 2, when it gets dragged down, you will find there is an acute weakness. So they all can present as GBS. But see the tone, see the reflexes. That will help you to differentiate.
Absolutely. Even sometimes even compared to spinal cord tumors, you may get the abscesses. Even abscesses we do come across commonly compared to spinal cord tumor.
Yes, very true.
And that even maybe the bacterial infection, not necessarily always tuberculosis, even bacterial infections. One patient I remember that present with the antivascular environment occlusion, and that was the case of falciparum malaria. Falciparum malaria blocked the vessel and presented as the paraplegia. Long back, almost I will say 15 years back, and that turned out to be ultimately the whole problem with falciparum malaria. Fortunately, recovered very nicely with his treatment and other, I will say, neurological support. But the point it was, Dr. Harshiti
It's an acute infarction of the spinal artery, basically, and that present, and that happens even post-operatively. That also we have seen.
So I think point is, don't block your mind with only GBS, transverse myelitis or something. Of course, these conditions are common. You will keep even common in your mind. But suppose if you are not happy, if you are not satisfied, then go beyond that. And beyond that, so many conditions can present with the various, maybe the neurometabolic, maybe the vascular, maybe something like that. Anything else, madam? Would you like to go?
So in summary, what I wanted to say was, always do not get biased. One, always see for the good clinical history and a very good clinical examination. And that makes most of it. So always evaluate, is there any atypicality? Is there, whether you have a dilemma between the tone, the hyper or the hypo, dilemma for the reflexes. If the reflexes are preserved, yes, it may not be the element type, it could be something else. So always a detailed clinical history and detailed clinical examination. And if you are not satisfied, do it again and scratch your mind. That will help you to find out in most.
Absolutely. It is said in neurology, I think as well in medicine, but more so in the neurology, that if you have taken the good history, 80% of diagnosis is almost GBA. You have made up your mind. Many times you're expecting that these should be my clinical findings. And if it is not there, probably it may be surprise to you. Then you may think something. But most of the times, which are good history, you can make up your mind for even the clinical CNS findings. And once you go for the thorough clinical examination, most of the times, at least diagnosis will be obvious. With the investigations, you want to confirm it. I think investigations are either for confirmation or excluding by the nearby differentials.
And that will narrow down your investigation as well.
Absolutely, madam. And that's why what madam said already in the ID chapter, we have prepared one module. And that is, as we are discussing antimicrobial stewardship, like that we discuss the diagnostic stewardship. And for diagnostic stewardship, you have the very good clinical diagnosis, so that you will not go for unnecessary investigation. And it is not only unnecessary or cost, even sometimes it misguides you. Something comes borderline, something comes falsely positive, that will misguide you. So it is not only just for this, I would say, saving the cost and other thing, but absolutely for even the reaching the correct diagnosis, the diagnostic, I would say, stewardship. And therefore, daily in the routine, I am asking my question, President, what you want to expecting to get from these investigations? What is your idea? So I think these questions all of us should ask. That was the, I would say, good point from madam, and it should be kept, I would say, as a whole in our daily practice. I think Dr. Anand, before we go for investigations, whatever Aarti has, any point from your side, please.
I think we have discussed almost all points. Okay.
Okay, so I think should we go for the investigations? Whatever Aarti must have everything ready. And that is also the drawback in the exam, because you are knowing the diagnosis. I would say that is the drawback, because whatever the examiner is asking, even you are knowing.
Yes.
But you are
It's
biased.
basically you get bias. It's a bias.
So that thing should not happen. Yes, Aarti, go ahead.
Yes. So should I continue with summary or investigations?
I think at least differential will have to explain on which ground you are
Okay.
considering all these.
Sir, it is
Yes, Aarti.
so my most the signs and symptoms with history suggestive of acute onset of flaccid paralysis. So my most probable diagnosis is transverse myelitis, because there is bilateral symmetry with proper sensory level, and so probable diagnosis is there. GBS and polio are less likely. But it is acute flaccid paralysis, so we can keep it in mind to rule out these conditions also.
Why not GPS? I will say it GPS.
Sir, if it is GBS, though there is motor involvement first, sensory can also be there, but bladder and bowel involvement will be later, sir. Not in the first day of presentation only. And it can further progress also. There can be ascending pattern of weakness, but there was no such pattern in this patient.
Okay. And why not the polio?
Because sir, in polio there will be purely motor, no sensory involvement usually, and it will be asymmetrical and not the.
Yeah, any other differentiating points from the anatomical? Yes, you are coming to the point. Involvement. Please use the multiple adjectives. Poliomyelitis is the acute. What further?
Sir, it will be the acute. Usually will present with fever, with asymmetrical weakness,
I
with
think
pain.
asymmetricity. Yeah, asymmetricity is very important. What Dr. Harshwati said, you know, isn't it will be patchy? It will be symmetrical, bilateral, or lower limbs only. We used to see that one lower limb weakness is there in the morning in the OPD. When you examine the next lower limb is involved, in the evening bulbar, and by the time next day fever. Yes. So it's a very common story, at least when probably around 80, when we were residents.
In epidemics also, we saw the same.
in one particular day, one of my colleagues on his emergency, he got 18 patients of poliomyelitis month of August. And out of 18, 15 patients death. That was the worst time I remember, somewhere in 81 or 82. In our BJ Medical College, one of the units, 18 admissions due to the poliomyelitis, and out of 18, 15 to 16th, deaths due to bulbar. This was the story. And that very classically, as I said, in the OPD, somebody is admitted with some doubtful weakness of one limb. When they are taking round in the 12 o'clock, one more limb is involved. In the evening, the patient deteriorated and bulbar. Before, and you know, this was the era before any facility, I would say ventilator or anything. Before you go for the intubation or something, the patient will die. So, but the very correct thing what Madam say, it's an acute, rapidly maritime progressive, it's an asymmetrical. Asymmetricity is the very characteristics. And then history of vaccination, other things you can take it.
Sir, in 92, we had an epidemic of the poliomyelitis
Yes.
in our area, and I had witnessed 100 cases.
Yes. That was the best,
So
I would say, worst time.
that was the worst time.
Worst
Yes.
time, yes.
I was a principal resident at that time, so I witnessed so many.
Right. Okay, so you can go further now, Aarti. You are doing very well.
So routine investigations were within normal. CSF examination shows cells less than 5 with protein 40 milligram per deciliter and sugars for 87. Fundus examination was normal and CPK total was done, which was also normal. MRI brain with whole spine was done with contrast, which was
Did
suggestive
you find the
of
LFT normal? Just to interrupt, did you find the LFT
Yes,
which
sir.
was normal?
Yes,
SGPT was
ma'am.
normal?
Yes, ma'am.
CBC was also normal because you said there was a history of fever and cough, and then following that, the child had a difficulty in walking. So we suspect some viral illness, and if it is so, you will find some rise in the SGPT or lymphocytosis. Usually, we expect the same.
Yeah. But I think that was the interval of some 2-3 weeks, he said. So
20 days interval, sir.
20
Yes.
days
It's
interval.
always 3 to 6 weeks, yeah.
Yeah.
You have to fundus examination is not an investigation; it is a clinical examination.
Examination.
Second thing is
Very
that
true.
you have to always mention blood sugar when you are mentioning CSF sugar. Here you mentioned about the CSF sugar 87. So what is blood sugar? Because in context, what is the relation? You know, na? What is the relation? Blood sugar and CSF sugar. And one question is, what is the albino-cytolic disproportion? What's the importance here?
Sir, it is present in GPS, in which cells are within normal, but the proteins are low.
Oh.
When do you get it?
Ma'am, in GBS.
Yeah, what
Of
time?
course, but on which? When?
Time, you know the time.
Sir, after 1 week, at least after 1 week, it is not
It's
advisable to
usually in
do
the second week. Yeah. Usually. And you must have done the CSF within first week, I suppose.
Yes, ma'am. Yes, ma'am.
So we do not expect anything unless it is an infection.
And second point, what is the mechanism? Why there is the albuminocytosis dissociation in the case of GBS? How will you explain? Why the protein is raised and cells are not?
So it is
Because-
basically the leak of the protein through the myelin, due to the disruption of the myelin sheath. Leak of the protein in the CSF.
But why it happens so Rajan?
Inflammation, sir.
Sorry?
There is a inflammation in nerve root, and due to that, we find the protein in the CSF.
Absolutely. You know, the nerve root is covered by the sleeve of this covering of the I will say
Myelin.
membrane, myelin, yes. And with this inflammation, that the breach, and therefore the protein will be raised, but not the cells much. Okay. As I think very good comment from Dr. Anand that fundus, don't take it the investigations. It should be the part of your examination. That means
Yes,
till probably we are not used to examine the fundus in the clinical examination. Okay, anything else?
Any special investigation you want to mention? You want to mention here?
Sir, MRI brain and whole spine was done, which was suggestive of focal non-enhancing intramedullary T2 hyperintensity in posterior part of spinal cord extending from T10 to T11 to T11 to T12 intervertebral disc level, suggestive of transverse myelitis most likely. No other abnormality on MRI study of whole spine or brain.
Arti, you have these plates?
Yes,
It is
sir.
there. Yes, I think
Uh,
neurologists can explain us.
Okay, put all so that we can tell you. Put all.
Yes, ma'am. Yes, ma'am.
Yes. See the hyperintense area below. It's a T10, 11, and just above, little bit above, you can see the hyperintense area on the sagittal section, and that suggests it is. I mean, the intensity is same as a CSF. You know, that is called hyperintensity. Above the
Right.
area is black, below there is a white. So that hyperintense just beyond the vertebra. Can you make it out? Because I don't have the pointer, but what I can see from the
Only Arti
this
can
one is,
do.
see the vertebra,
Uh,
then there is a layer. Yes, sir.
Here, ma'am.
See the vertebra, then there is a thin line white, which is a lipid layer. Then there is a black line. The black line above is a spinal cord and below is a hyperintense area, and that is suggestive of an edema. The same thing you can see in the coronal section where there is a whiteness around the hyperintense. I mean, there is a hyperintense area around the black area, and that is suggestive of an edema. So what you have to see is not enhancing, but it is there should be the diffusion restriction. And it did they do the contrast? Do you have the
Oh, ma'am,
contrast?
this. Yes, ma'am.
No. Where is the contrast? I don't see the contrast here. Where is the contrast
Ma'am.
plates? They are not a contrast plate.
If you have
Because-
other
Ma'am,
links, you can show.
I'll have it, ma'am.
Okay.
You can show.
So any role for nerve conduction study, in the case of GB, in a acute flash study, we can say, in the what other test you can do, if money is not a problem, what other test you can do with the CSF, all these things may ask for examination. CSF, you just mentioned about cells and other things, but examine other test you can do with the CSF. What is oligoclonal gland?
Yeah.
Also, again, other different modality, other tests also you have to keep in mind.
Yes, nice. Now everybody can differentiate the lesion. I think the one which is enhancing the white area on the top on the from the left to right, my left to my right. The first two is showing an enhancement. Below that, that is still it is going down and down, but that is not showing an enhancement. That's an edema. But this is not non-enhancing; it is enhancement seen. Okay, so that shows an edema. Whenever it is an edema, it will show the enhancement. They have not put. But there will be diffusion restriction when there is an edema. You will find diffusion restriction, and there is an enhancement. But it is not a cytotoxic edema. That's it.
Is sagittal section?
Yes, sir.
Yeah, it is there.
Yes. Now.
Dr. Harshita, you are muted. Unmute yourself. Yeah.
What from this sagittal image is, yes, where there is your pointer. Can you show me where do you find edema? Then I will say yes or no. Below, on this side, first left of mine, first left,
Here,
first
ma'am.
left. No, even before that, first one, yes.
Okay.
Now you start counting either from below or from above. From below you can see if you don't have much, see 1, 2, 3, 4, 5, 6, 7, T1, 2, 3, 4, 5, 6, 7, 8, 9, and 10. Now, can you see this? Can you count it? Yes. That's
Somewhere
an
here,
area.
ma'am.
Yes. Can you see the enhancement, the black, dark black area?
Yes,
Yes, ma'am. Yes, ma'am.
Yes, that is an edema,
right.
right? For rest of the things, it is an overcrowded. They have focused more on the vertebra, less on the core. So it's difficult. But if you see the last plate, yes, the last of last,
This
you
one,
can
ma'am.
see the lighter area at the D10, 11, 12. You can see the lighter area. Last, my first right. My first right. You see the first
Extreme.
left.
Yeah.
This
Okay.
one, ma'am.
I cannot see your pointer, otherwise I can help you.
Yeah, it is not seen.
Yes.
Now the
Yes.
pointer is
This is
seen.
left and this is right. Go to the last. Go to the last image. Go to the last image.
Arti,
Yes.
yes,
Your pointer
Arti.
was right. Everybody can appreciate. Just I'm
Yeah.
making it white so that everybody can appreciate the wider and the hyper intense area, the white color.
Yes.
At the bottom, first and second, both images from the left is showing hyper intense area between T10, 11, 12, and first L1. This is all which is hyper intense. It is not only T10 to 12. It is T10 to L1. It is a hyper intense area. Can you see? You are putting pointer on the right. I am asking you to just move, still move, still move, still. Yes. Now focus on, no, here. Now focus on
Okay.
this image.
Okay, this,
See
okay.
from above. See from above. Okay. Yes. Where your arrow is, can you see the hyper intense area which is starting from T10, 11?
Yes, ma'am.
You put your pointer on the T10. You are not on T10. You are at the L5. Just go ahead. Go above.
T10 will be above.
Still
Arti.
above. Still above. Still. Yes. This is the point from where the edema is starting.
Okay.
So it's a long segment transverse myelitis
Right.
where it has more than 3 segments. And this is T10, 11, 12, and L1. So it's a 4 segment. So this could be not an isolated transverse myelitis, but what it could be?
Ma'am, longitudinally extensive transverse myelitis.
What it is known as a?
Ma'am, myelin dendrious.
No. I do not know. It's a NMO.
Okay. NMO.
Okay.
Yes,
Neuromyelitis optica.
segment transverse myelitis. You always screen for the brain. You always see for the optic nerve. You always see for the optic nerve edema. If it is there, you may find some hyperintense area, or else you have to go for the serum aquaporin antibody for this child. Yes, serum. It is always from the serum, mind well. So it is a serum aquaporin. The name itself is suggestive. It is a water.
Yeah.
So it's a aquaporin antibody, and that you have to see in this child because it is not 2 segments, it's a 4 segments. So it's a wider area which is involved. Why we are doing is there are chances of recurrence of the same kind of weakness.
Right.
And you have to have a immunosuppressive therapy for at least 2 years.
Okay, ma'am.
Okay. Nice. Always the MRI is to be, it's very easy.
Yeah. Anything to show?
Yes, sir. Just 2
Okay,
slides
you can take it. You can take it.
Sir, treatment-wise, child was orally allowed. Injection methylprednisolone was given for 5 days, followed by tapered dose of prednisolone for 1 month. Physiotherapy was started. Symptomatic treatment for constipation was given and encouraging regular bladder voiding. Improvement was noted within 5 days of admission. Child started moving legs and hip flexor strength returned to power 3 at the time of discharge. So this is the previous admission. So current status is child is walking independently, no urinary incontinence and normal bowel habits. Abdominal reflexes are present below umbilicus, but plantar are still absent. Tone is normal and power is 5/5 in both lower limb. So this was the after 3 weeks of illness video. The video was taken with consent of the child and parents both. 1 minute. This was the first video, sir. And
Yeah.
after 2 weeks of that, the gait has been improved. So
It improved, but she is still having some weakness on
Yeah,
the
some weaknesses
right
there.
yes,
lower
ma'am.
limb. Yes, she is
Yes,
But-
dragging her foot.
Yeah, but good recovery is seen.
Yes, good recovery, but she is likely to recur also. It's a
Yeah.
good recovery with a high chance of recurrence, which one has to keep in the mind and keep the
Yeah,
child
yeah.
on follow-up. Yes.
I think, is it so, Dr. Harshiti, in this type of the
Mhm.
case, it just my highlight is that if the rapid onset,
Mhm.
then the recovery is slow, and the slow onset, the recovery is good. Is it so? I don't remember, but I think
I
something
don't think
like
so.
that.
No,
Yeah,
no, no.
yeah.
It all
It's a-
depends upon the spectrum. If it is an aquaporin, I
Spectrum.
mean positive, yes.
Okay.
Then the recovery would be slow. Then the
Right.
recovery would be slow,
Right.
where the treatment is again either IVIG or a plasmapheresis. It's a
Right.
treatment for the choice. Yeah.
Okay, Arti, you can just
Good
stop
evening.
sharing. Support the thing
Yes,
is there.
sir.
Very
That
good.
is it.
Yes, Anand, ક્યાં હતો તું?
But no, I'm not joining you, sorry.
પણ આ તો તમે મેન્ટર છો ને તમે આવું કરો. સર આનંદ મારો સ્ટુડન્ટ છે. I can tell him.
Oh,
Sorry, but I think
very nice to see you, Dr. Anand.
I'm very proud to be your student, madam. Yeah. And actually, Aarti and I, we had a lot of discussions about this case. But I just wanted to
Okay.
clarify a few things, madam. I think it's a bit difficult to see it on the plate. But actually, there is no sagittal change on the sagittal image at all. This was a very, very focal lesion only around T10 and 11. So it is not a longitudinally extensive transverse myelitis. It is a
Okay.
small segment myelitis only. And
Okay.
we did consider sending aquaporin as well as MOG antibodies. But in view of the
Mhm.
fact that it was a very acute onset, the fact that she responded so well, and also the affordability issues, we then decided not to send the MOG and aquaporin antibodies because parents were not affording for that. And also, we did think about oligoclonal bans, but again, it was because of familial affordability as well as the fact that there was no dissemination to the cranium. MRI was normal. There was no other, features to suggest an alternative diagnosis like multiple sclerosis. So we didn't push for it. Otherwise, actually, in the private setup, we would send for both of these things. And
Always,
Aarti and I,
always,
we had a
never
discussion
miss.
about,
Yes, always.
Yes,
Never miss. Okay.
Yeah.
Anyway, anything, Dr. Anand, from your side, or should we go
Close
for
it.
end over here?
No, I think Aarti has done a very good job of presenting. I think, and she kept
Yes.
on discussing with me, so I'm very
Yes.
happy that she did well.
I think Arti has done the really good presentation. We understand that after even 2 to 3 years of pediatrics, to present the case in these details, with these all the ideas, even the way which she responded to most of the questions, it definitely very few students can do. So certainly, number one, it was the selection of case was good for all of us to learn. The way which probably she gathered the information in the history and examination findings are definitely quite appreciable. And I think the presence of two experts, Dr. Harshiti and Dr. Anand, made the difference in understanding the whole case, its interpretation, and how even we should manage differentiations and so many things. And Dr. Anand Iyer, thank you very much being the mentor and I would say preparing this type of the case. Definitely not only for the students, but for all of us, it's a best I would say learning
learning.
exercise. Certainly,
Good.
certainly.
Sure.
And
Thank
even
you, sir.
and even all other students also, Dhaval, Rajat, and others, I will say their participation, their even I will say responses, questions, definitely it is quite appreciable. Thank you very much, all of you. And
Thank
I
you.
think hand over this further procedure to
Nehal.
Dr. Nehal, please. Thank you very much.
Thank you, sir.
Thank you so much,
you.
sir. Thank
Thank you.
you, Aarti, for presenting the case so nicely.
Yes,
Thank
sir.
you, Anand, sir.